on the lawn.
Yeah.
So you see something that is somewhat blue and trabecular. So you mentioned possibility of Merkel. Does Merkel usually have visible cytoplasm?
No.
And do you see visible pink cytoplasm here?
I do.
So, certainly neoplastic, certainly a trabecular type pattern, maybe a little more cytoplasm than you would expect for Merkel. So we can go a little higher. And certainly lots of mitotic figures everywhere you look. Cells are highly malignant, and then you have some cells that have this morphology. See how you have a big round cell with red cytoplasm and a nucleus off to the side?
Mm-hmm.
And there are lots with that morphology. That's called rhabdoid. So in rhabdomyosarcoma, you have cells that, oh, that looks just horrible up on the screen, doesn't it? Not quite sure why that's so bad up there. Let's get, that's better there. So that's your rhabdoid cell right there. So in rhabdomyosarcoma, you have cells that are trying to be striated muscle cells, but the best they can do is an eccentric nucleus and a big blob of red, right? So that's called rhabdoid. And when you have a highly malignant cell population with lots of rhabdoid cells, that's typical for melanoma. So, melanoma can have lots of different patterns, but the rhabdoid cytology is very helpful and is typical.
Is that a melanoma? Yeah.
That was melanoma.
That's a hard one. That was weird.
Well, it's a little different, but melanomas have all sorts of different patterns. In that one, you had a highly malignant cell population with visible cytoplasm and a rhabdoid cytoplasm.
So rhabdoid doesn't mean muscle.
Rhabdoid means oid, so it's mimicking what muscle tumors do.
But it's not a muscle tumor.
It's also the most typical cytologic feature of melanoma. So melanomas are often rhabdoid. Hepatic tumors are often rhabdoid too. So you'll hear general pathologists say melanoma looks livery to me. What they're talking about is that rhabdoid morphology.
Is that which one the worst prognosis? Like, is that more
Those are usually bad. Yeah, they're usually bad melanomas. They're usually metastatic melanoma when it looks like that. So when you have a MET and you're trying to decide what that MET is, and you have a rhabdoid, you have rhabdoid cells, that's commonly melanoma. Okay.
So there appears to be something in the superficial dermis next to that follicle. I'm not sure. Yeah.
So you got some little round nests here.
Yeah. There is also some nesting, the degeneration. J. There may be a little bit of scar, so I'm thinking at this point recurrent residual nevus.
Sorry, I'm trying to get it to weight balance again. There we go.
But there's also pigment. I'm not sure if that pigment.
Yeah,
is
so there's some pigment incontinence. The nests here look pretty bland. You were looking at possibility of scar and so possibility of recurrent or residual nevus. Could also just be papillodermal fibrosis, like an atypical nevus. The junctional component goes out a little bit, probably 3 ruddy ridges beyond the dermal component. So kind of a wimpy dysplastic nevus or wimpy atypical nevus would be about right. It is not on automatic exposure. It says it is.
Yeah, we all gave it to you. It's
This guy didn't give anything back. Not to good though, I feel like. No, I feel like I do.
there's a lot of fat.
There's a lot of fat,
So
and within the fat, lots of little
blood vessels. So,
weak thrombi
so it's going to be an angiolipoma.
and angiolipoma. Very good.
Thank you. Not really remembering anything.
It looks like there's a pustule there in the epidermis.
So, what would your differential be?
Like psoriasis, candida, impetigo, stats.
So, candida, psoriasis, tinea impetigo, candida, sebderm, syphilis, P-tics. Also with subcorneal pustule, you have to think of things like Snedden-Wilkinson, IgA pemphigus. So that would be a very good differential. And, that one was pustular psoriasis, but it could easily be any of those things.
So you have a superficial and deep infiltrate here. So looks like there might be some mucin. So you may think about connective tissue disease.
So you think about connective tissue disease. Tell me about the collagen in the superficial dermis and compare that to the collagen in the deeper dermis.
It's very sclerotic in the deeper dermis.
Very sclerotic, hyalinized, loss of space between collagen bundles, some loss of periadnexal fat, nodular lymphoid or lymphoplasmacytic infiltrates. So what are we looking at?
So like scleroderma.
Yeah, morphia. Yeah. So inflammatory morphia. Very good.
We'll shave biopsy. So there's a perforation in the epidermis. Is this it's a little bit warty, like a trichomoma, perhaps, or
A little warty like a trichomoma. So trichomomas usually have hyperkeratosis, a little bit of hypergranulosis, so they resemble warts, but they have clear glycogenated lobules that hang down from the epidermis, a peripheral palisade, and peripheral to that, a thick glassy basal membrane zone. I think that's very good as a trichomoma. When solitary, it means,
nothing.
and when multiple,
Cowden's.
very good.
So the cystic perforation in the dermis looks like it's filled with kind of like kind of amorphous, like myxoid material.
So is it amorphous and myxoid or feathery crystals?
Feathery crystals, so like gout maybe?
Like gout, very good.
Looks like punch biopsy.
Punch biopsy, very good.
Looks like infiltrate in the deep dermis, maybe in the fat.
So tell me about this collagen. Does it look like that collagen?
Not really.
Okay, so which one's normal and which one's abnormal?
Well, it's a light slide, but I would think up there's abnormal.
Up there is kind of abnormal. It's all washed out and edematous and smudged. So you have a compact hyperkeratosis up at the top, and effacement of the Reedy pattern, a big pale zone of smudged epidermis, and then a lymphoid band below it. What is this?
LSNA.
LSNA. Just a big wide zone of lichen sclerosis. But remember, very patriotic, red, white, and blue. So you've got your red hyperkeratosis, your white pallor, and then the blue lymphoid band. Well done.
Sclerotic, kind of busy, superficial and mid-dermis.
Yeah, sclerotic, kind of busy, and the collagen fibers are kind of haphazard bundles, right?
I thought about GF with the kind of reactive acanthosis above it.
So dermatofibroma, especially if there's a little reactive acanthosis.
I mean, a little sparse, I think, for GA. I don't really see any mucin unless
That's
it's like
another thing that would
interstitial.
be a busy dermis would be granular manulary. The other thing with those being just sort of big, thick, haphazard collagen bundles is what if this is a collagenoma of some sort? So if it were big and deep, you'd think of nuchal-type fibromas that look like this, or when it sits just up in the dermis and it's just a dermal plaque, then connective tissue nevus. Does this look like it's mainly collagen or mainly elastic?
Mostly collagen.
Mainly collagen. Do you know any type of collagenoma?
Those we just stated?
So So what connective tissue nevus is almost totally collagen with no elastic?
Collagenoma.
Yeah, which is shagreen patch of tuberous sclerosis. So TS is almost purely collagen with very little elastic. Most sporadic connective tissue nevi are both collagen and elastic. Shagreen patch, almost all collagen, no elastic. And then which one is almost all elastic, no collagen?
The Busch-Gallendorf.
Busch-Gallendorf. Okay, so you've got connective tissue nevi, which are like CT nevus NOS, which is both elastic and collagen. You've got shagreen patch, which is almost all collagen, and Busch-Gallendorf, which is almost all elastic. Very good.
Looks like a issue from the April skin, or at least hyperkeratosis, if not.
Agreed.
Looks like there's a lot of cellularity in the dermis too, and maybe some like ectatic vessels in the upper dermis.
So very ectatic vessels up high, and they almost kind of sit up in the papillae.
Like some kind of angiocarcinoma or fibroma.
Yeah, it looks kind of like an angiokeratoma or a lymphangioma, depending whether there's heme or lymph there. But you noted that in addition to that, there's a busy dermis. And in fact, there is hemosiderin down in that busy dermis. And a little bit of vascular proliferation around pre-existing vessels. So this would be a good thing for an upper year. What looks like lymphangioma or angiokeratoma up top, but looks kind of like Kaposi's down deep with hemosiderin and tufting of new vessel formation around pre-existing structures.
Targetoid hemosiderotic.
Well done, Robbie! Very well done. That's exactly right. So THH, or targetoid hemosiderotic hemangioma. The other name is hobnail hemangioma because when you look at those little spaces that look kind of like angiokeratoma, they're different from angiokeratoma. And how are they different? Because they have big hobnail endothelium sticking into them. So hobnail hemangioma, or targetoid hemosiderotic hemangioma, looks like an angiokeratoma or lymphangioma up top, but down below it has hemosiderin, a busy dermis, tufting of new vessels around pre-existing adnexal and vascular structures. So that combination is good for a THH, also known as hobnail hemangioma. Very good.
Oh, sorry.
Oh, we got two different things here. First off, what's on that side?
A sib.
A seb. And what's on this side?
Like an AVM.
Like an AVM. So thick and thin muscles, or thick and thin vessels. Thick muscular vessels, thin vessels, arteriovenous malformations. You got a little twofer there. Okay, so Shane,
And the dermis.
is the process you're seeing top to bottom, side to side, or is it focal and patchy?
Focal and patchy.
Focal and patchy.
Like histiocytic. Right.
So lymphs and histiocytes, interstitial, focal and patchy, what would that usually be?
So like GA.
Like granular mammillary. Very good. And if it looks kind of like GA, if the person has a rope-like thing down his flank, is there any kind of interstitial granulomatous dermatitis that does that?
Yes, the latter there.
Yeah. So it's called IGD, interstitial granulomatous dermatitis. Has the rope side, looks similar to Mondor's disease, where you've got something looks like a thrombosed vessel or something snaking down your flank, and then looks like interstitial GA histologically.
There's a lot of crystals. I think these are cholesterol.
So cholesterol clefts, and then what's the lesion?
So there seems to be like a cavity, like a cystic.
Like a cystic cavity.
Yeah.
And
but
the
there's
cells become flat before they keratinize, or abruptly keratinize and remain round,
abruptly keratinize around. There's
which would be characteristic for
like a pilar cyst.
pilar cyst. But what's wrong with this pilar cyst?
It's got like scrolls.
It has like scrolls. So do you know any kind of proliferating pilar cyst?
Pilar.
Yes. Proliferating pilar cyst. Very good.
Sheaves.
And where do you think you are?
My face.
And how wide a specimen is this?
This is a really wide specimen.
What would compel you as a dermatologist to take this big a swipe of someone's face?
My concern is Lentigo maligna.
You are correct.
There's
So,
some-
you know, big, broad shaves. They were usually looking for MF or LM, right? And MF is usually not going to be face.
A little nest right there. And then just some irregular nesting throughout. But there's not a great pigmented proliferation that I can see. There's another nest right there.
No, exactly. So this is not something that jumps right out at you. But talk me through it.
So,
Are all of them nested, or are there a fair number of non-nested
no,
melanocytes?
there are single melanocytes and then some nests that kind of go across reedy and bridge reedy as well. I mean, there's not a lot. There's
And
not.
is that a round nest, or does it have kind of a little point up top?
It's a little atypical.
Yeah, so weird shaped nests. And is that sitting at the tip or side of a reedy, or is that kind of up in the epithelium?
It's up in the epithelium. There's just not a lot of solar elastosis for all.
No, so not a whole lot of solar elastosis. It doesn't really jump out at you as deeply pigmented lesion, and yet it's poorly nested. There are areas where non-nested melanocytes predominate over nests. The nests are irregularly shaped. They're not all at tips and sides of reedy. So you absolutely can get there. And you've got the clue of someone taking a big, broad swipe off of a face.
So we're down in the fat.
Correct.
Um,
And what's wrong with the fat?
some death appears.
Or is it all fat, or is there a lot of fibers?
There's a lot of fiber stuff. I can tell that's pink.
So there's a lot of the fat that's not fat, right?
Mhm.
It's fibrous. And is the collagen normal or is it weird?
Weird.
So you got hunks of weird collagen in the fat. Some areas where it's more
More cellular.
cellular and spindly and a little mixoid. Other areas where it's more mature.
Mm-hmm.
So any thoughts?
I mean, some sort of like. I mean, it doesn't look like DFSP, like going down through the fat. You think of that, but this does not look as cellular.
Agree.
enough and intense
Agree.
enough.
So that would be a malignant DFSP would be a malignant fibrous tumor in fat,
Just
but
like a fibrous
it has
cystosome.
lots of nuclei, and this doesn't have lots of nuclei. So you're correct. So what else?
Like a fibrous histiocytoma.
So fibrous histiocytoma, which is basically dermatofibroma, would be one thought.
Spinal cell lipoma.
So a mature spindle cell lipoma, which becomes then a fiber lipoma, or a mature fibrous hamartoma of infancy. So either one. So either fibrous hamartoma of infancy that becomes mature, or a spindle cell lipoma that has just matured into a fiber lipoma. So late stage of one of those two things.
So you have a little shape here, a glycogenated area there. That makes me think of sort of a tricholamoma.
So trichomoma hangs off of the epidermis. Is this hanging off of the epidermis, or is it the epidermis that's glycogenated?
It is the epidermis.
So it's the whole epidermis. It's not something hanging off an epidermis. It's the whole epidermis that's glycogenated abruptly, has a neutrophilic crust and neutrophil fragments and debris within it.
A clear cell
A clear cell acanthoma. Absolutely. And I guarantee trichomoma would be on your pick list, right? So, whatever you were thinking, it's there.
Just probably a little papule. There's lots of kind of ectatic vessels superficially.
Ectatic vessels, and are they big and round, or are they all kind of flat?
I mean, some are a little round. They're definitely not all flat, but most of them are probably flat. There's
Yeah.
definitely fibrous proliferation. I mean, it could be angiofibroma or other, I don't know, some other.
Do you know any kind of angioma that's microvenular?
Microvenular hemangioma.
That is correct. Microvenular hemangiomas. The microvenular hemangioma just lives up to its name, where it's got all those little flat vessels.
So, on the superficial dermis, I have a position. So, I guess you could think about like an amyloid, maybe, or
So the stuff you're seeing,
or is it more lymph?
yeah, it's
So it's-
lymph and it's in dilated and
Okay.
endothelial line spaces,
So, like a lymphangioma circumscriptum,
like a lymphangioma.
microcystic lymphatic node.
Yeah, so lymphangioma, and the endothelium does not appear particularly hobnail. If it did, you might look deeper to see if there were THH underneath. This one is just lymphangioma and not particularly hobnail endothelium.
Looks like a cyst or something.
Like a cyst, so a keratin-filled thing that is follicular and opens to the surface. If you had lots of those on your nose, you'd call them. They'd look kind of blackhead-like.
Like a comedone?
Yeah, so you've got a big comedone there, and then you got scar, and then you got pus, and you got sinus tracts.
Like nodular cystic acne?
Like nodular cystic acne, absolutely. What if this were an axilla?
HS.
Yeah. exactly. So nodular cystic acne, or HS, which is basically like nodular cystic acne in an axilla.
A deeper cut here. Looks like lots of almost lymphs, but a lot of them almost looks like they have crush artifact peripherally.
So they look like they have crush artifact, which suggests usually that it's a malignancy of some sort. So things like lymphomas do that.
Yeah. That'd be where I'd be concerned. I mean, the center kind of has a little bit of the trabecular pattern you might see with Merkel, but I think...
So you definitely have parallel wall-like structures, which is a trabecular pattern, which is a hint to Merkel, and they are small blue cells with very little cytoplasm.
Mm-hmm.
So Merkel would definitely be there with the crush artifact. Lymphoma would be there, neuroblastoma, PNET, peripheral neuroectodermal or primitive neuroectodermal tumor, the Ewing's essentially. All of those small blue tumors. So anything you want to do with it?
Imagine this would get a fair share of stains.
So you'd probably want to get stains. Start with things like a keratin 20. Let's also look a little higher at this. So when you look at it, see that cell there? See how it's got an eccentric nucleus and a big red blob next to it?
Mm-hmm.
What morphology do you call that in a cell?
I believe that would be rhabdoid.
Rhabdoid. Do you know any sort of small blue cell tumor that has rhabdoid morphology?
It could be melanoma.
Or rhabdoid because it's a rhabdo. So rhabdomyosarc. So melanoma is usually not small blue cell tumor differential, but rhabdos are. So this is where rhabdoid gets its name, because it's the morphology. You got a small blue tumor that just here and there is tipping its hand that is trying to form muscle by creating those rhabdoid cells.
Definitely have something, looks like within the epidermis there.
Something within the epidermis, nested. So are the nests A, all round to oval at the tips and sides of redi and equally spaced and similar in size and shape, or B, not all at tips and sides of redi,
Whatever it would be.
vary in size and shape, vary in spacing?
Yeah.
Okay, so would this be a good friendly thing or a non-friendly thing?
Probably pretty non-friendly.
Probably pretty non-friendly. So melanoma. Nests vary in size and shape, not equidistant, not at tips and sides of redi.
So, pretty nice basket weave orthokeratosis. You've got some neutrophils collecting in the dermal papilla, some extravasated reds. Be worried about DH linear IgA.
Yeah. So there are areas where the neutrophils line up along the DE junction, like there was maybe linear immunoglobulin, and some areas where they cluster in the dermal papillae, as if there were granular immunoglobulin with a picket fence pattern in the papillae. So this one can't decide what it wants to do by pattern. So what's your full differential for this?
So DH, linear IgA, EVA, neutrophil rich BP.
Exactly. So this is your whole plaid differential. P for pemphigoid, L for lupus, bullous lupus, A for EBA, I for linear IgA, and D for DH. Very good. That sounds horrible. Hot tea with lemon.
So we have some serum crust and some pustule.
Serum crust and pus, and the pus is
Kind of within the layers subcorn.
Yeah, so subcorneal pustule, what is your subcorneal pustule differential?
Oh yeah, like Ajax.
So acute generalized xanthematous pustulosis, Snedden-Wilkinson, and a lot of Snedden-Wilkinson is really IgA pemphigus, pustular psoriasis, tinea, although that would be a lot of pus for tinea. So you've got your whole newts in the horn differential, tinea, impetigo, candida, sebderm, syphilis. It's probably too much pus for any of those. But then your subcorneal pustule, acrodermatitis of infancy, or acropustulosis of infancy, which is post-scabetic, neonatal pustular melanosis, transient neonatal pustular melanosis, Snedden-Wilkinson, IgA pemphigus, pustular psoriasis, acute generalized xanthematous pustulosis, all those things that give you subcorneal pustules. And this one, by history, was a Snedden-Wilkinson. But it could be any of those. Let's skip that. This one.
So you have a sparse gray vascular lymphatic infiltrate. A lot going on, normal circumflexion, normal epidermis.
Now, it's a normal vascular corneum sitting on top of a very compact red zone of corneum.
So that makes you think more of like tinea.
Exactly. So that's your scan hint for tinea. Compact underneath a normal basket weave. So, where do you think you are?
It looks like mucosa.
Yeah. And does the top look normal, or does it look like it's been chewed on?
Chewing.
So it looks like you're chewing on your mucosa. And why are you chewing on your mucosa?
Because it's a bump.
Because it's a bump, a big collagenous bump. So do you know any kind of submucosal fibroma?
There is the fibroma, submucosal type.
Yes. The fibroma, submucosal type would be the major one.
So it looks like you're most likely on facial skin here.
Most likely on facial skin. Big piece, little piece.
Pretty broad.
Pretty broad. Why would anyone do such a thing?
So you're looking for LM versus CTCL, and it looks like there's some possible proliferation at the DJ that's so nested.
So you see nest. Is that nest nice and round to oval, or is it kind of weird and long?
It's kind of weird. It looks like they go down hair follicles a little bit.
So you have adnexal extension, and you have areas that are poorly nested and arch involvement. So what do you think? LM.
Is there any spindle cell component underneath that area?
Let's go. So your point is that anytime you see an acral type of melanoma, you have to worry about the possibility of underlying desmoplastic melanoma. You have some red fibrosis of the papillary dermis shifting the elastosis down, which is common in laryngoma maligna. If there's ever a question, what stains would you get?
Yeah, SOX 10.
SOX 10 or S100. What stains would you not get?
Would not get marked for an HMB.
Yeah, so MART and HMB45 are unreliable in any spindled melanoma, whereas SOX and S100 remain reliable. Very good. Skip that one. We're going higher yield.
So we have a pigment effusion here, very dark.
And someone obviously excised it, so they were worried about it because it was very dark.
It has
But
the
is
morphology.
it very broad, or is it kind of circumscribed?
Circumscribed. It has a morphology like a Spitz nevus.
Yeah. It has a morphology like a Spitz nevus, ends abruptly in a nest, is small and circumscribed, but it's heavily pigmented, does not look like facial or head and neck skin, and it's composed of small spindle cells in round to oval nests at tips and sides of reedy. What would Dr. Reed have called this?
pigmented spindle cell.
So pigmented spindle cell nevus of Reed is like a small spindle cell spitz on the extremities, proximal extremity of women. They tend to be eruptive, so you have this dark thing that just appeared. And, you know, she's 32, she's got a kid at home, she doesn't want to take any chances, she says, cut this thing off. So it's not uncommon that they're biopsied or excised, but the clinician usually tells you, boy, it was really dark, but it's small and it's well circumscribed, but she tells me it's brand new. And it's proximal extremity of a young woman, and it is well circumscribed, ends in a nest, looks kind of spitzy, hyperkeratosis, PEH, hypergranulosis, but is darkly pigmented, and whereas spits are composed of large spindle and epithelioid cells, these are composed of small spindle cells only. Very good. So depending on whether you're a lumper or splitter, it's either, you know, a small cell spits, or it's different because it's small cell and not head and neck of kids.
All right, so in the dermis, very busy. Looks like maybe granulomatous.
Looks like a granulomatous infiltrate. So are these granulomas naked or dressed or partially clothed?
Partially clothed?
Yeah, these are kind of partially clothed. They can't decide, right? So a lot of them have no lymphs, which would be naked granulomas, and then some have lymphs, which would be the opposite of a naked granuloma. So for the ones that are naked granuloma, what's your differential?
So yeah, the main thing I think about is sarcoid.
Sarcoid, but sarcoid's not on my pick list. So what else looks like sarcoid?
So as far as
yeah, so I heard people are murmuring like they're doing the cough clue that so Crohn's, some infectious like leprosy, especially if they're deeper and parallel to the surface, silica granuloma, beryllium granuloma, zirconium granuloma, all the things that are Crohn's or sarcoid-like. Crohn's, the typical would be a little girl with a massively swollen vulva, sometimes ulcerative and nodular on the shins, but more commonly it's kids, more commonly it's a little girl, and more commonly it's a vulva that's just big swollen in a little girl. That would be common for, you know, early IBD presenting in a child. And then for the granulomas that have lymphocytes.
So, I mean, like a rheumatoid nodule, or like granulomatous.
So I don't particularly see a palisaded granuloma with fibrin, like a rheumatoid nodule, but granulomas with lots of lymphs around. Back in the days, you know, when TB was common, that's what distinguished TB, lupus vulgaris, from sarcoid. Sarcoid was naked granulomas, and TB tend to have lots of round cells around it. So you're more on the infectious granuloma side if there are lots of lymphs, and you're usually non-infectious granuloma if they are naked. Or, since I was taught derm path by Southerners, naked.
Like papillonous growth. There's inflammation in the superficial dermis.
Are all the keratinocytes the same, or do you have two populations of keratinocytes?
There's two populations.
And is the one in distinct clones or nests?
Not really.
Yeah, I would have said yes, but that's fine. So I'd say, like here, you've got a pretty normal epidermis, and then sitting within it, you got that nest of the smaller cells.
Okay.
So if you've got clonal populations
Like
in the epidermis, so clonal seb, or what if they were ugly cells?
Like SECIS.
Yeah, like bones or squamous in situ. And what if they were bland cells like clonal Seb, but had duct differentiated?
Hydroacanthoma simplex.
Hydroacanthoma simplex. Very good. Excellent.
The vessel's almost like just a hemangioma.
Like a hemangioma, and are those tiny little tablet-sized vessels or big vessels?
Much larger.
So if you were spelunking, would this be more like a little wormhole or more like a big cavern?
a cavernous type.
Like a cavernous hemangioma. Yes, very good.
With histo.
And the nice thing is on all exams they give you clues like that on everything.
That's what I keep hearing about it. Word.
So. Okay, where do you think you are?
Maybe on the scalp?
Maybe on the scalp, and then what's wrong with the scalp?
Oh, there are hair follicles in this portion.
Yeah, there's a big broad zone with no hair follicles, and then you get to the other side and there are hair follicles again. So what would give you a big, broad, hairless patch on a scalp, and the collagen's pretty small and red, so it's probably a kid.
Like a early nevus sebaceous?
So early nevus sebaceous, you're going to see tiny little hair germs all lined up vertically, right? Whereas, and that looks pretty atrophic and scar-like.
Like
so
an aplasia.
Like an aplasia cutis, and then you always look underneath for meningocele, because aplasia cutis often has meningocele underneath it. Here we don't see anything underneath. Meningocele would look almost like angiosarc, vascular like crack-like spaces sitting under a zone of aplasia cutis.
So, sebaceous proliferation is predominantly mature pseudocytes, and then just sebaceous adenoma.
So sebaceous adenoma, there are areas of immaturity and it's a little bit large, or sebaceous hyperplasia if it's small. We used to be big on getting MLH, MSH, but now it's looking more and more like those are gone. One or the other is gone in a lot of them, but the patient doesn't have muratory, and it's almost akin to neurofibromatosis, where any neurofibroma is going to have lost neurofibromin. That's why it grew, but that doesn't mean the patient has neurofibromatosis. So patient evaluation is probably more value than a histo evaluation of loss of markers.
So, very pink cells.
So are you thinking inflammatory or neoplastic?
Probably.
And if it's neoplastic, this is pink, and you got little white circles, so what would be pink with ducts?
Like any kind of, just in the kind of that group.
Yeah, acrospiroma group. So acrospiroma group is pink with ducts and does not palisade. Blue with ducts. Anybody? Sebaceous. So blue with ducts, especially blue with circular red ducts, is sebaceous. Pink with ducts is acrospiroma. You can see areas where it becomes cavitary, where it's filled with amorphous pink sweat, so it's a Schveddy tumor. And you have these areas of osteoid-like stroma with tiny little blood vessels embedded in them, so characteristic for the acrospiroma poroma group that it gets called poromostroma. So poromostroma looks almost like hunks of osteoid, but with tiny little blood vessels in it. So poromostroma, sweaty tumor, pink with ducts, would be something in the acrospiroma group, which are all the hydradenomas, poromas, all the same.
Sorry, I didn't know.
Okay.
So we are on facial skin here. There
Okay.
seems to be nodular infiltrate, mostly in the deeper dermis, also around hair follicles, some serum crusting and erosion at the top.
Yep.
So,
And it's in the eccrine coil.
yeah, so that's concerning more for like connective tissue disease.
So lives in the eccrine coil, lupus, lymphoma, lichen striatus. Here you've got a patchy lymphoid infiltrate on the face, so you're worried about connective tissue disease. Tell me about the fat.
It's definitely having some, like necrosis to it almost, like the septum are enlarged, but you're also getting more of that chicken soup type of
Yeah,
lymphosis.
so instead of all the circles being the same size as in a septal paniculitis, the circles are different sizes, suggesting it's a lobular paniculitis, and it's intensely staining red. What is intensely staining red stuff?
The
Fibrin. So you have a lobular paniculitis with fibrin and nodular lymphoid or lymphoplasmacytic
So you
islands.
like lupus paniculitis.
Lupus paniculitis, very good. So you could handle this slide either way. Either the surface, which was patchy lymphoid with eccrine coil involvement, and some mucin, which is lupus lymphoma lichen striatus, and probably lupus given the mucin in the dermis. Or you could handle it as a paniculitis, in which case you have a lobular paniculitis, big circles, little circles, fibrin, nodular lymphoid or lymphoplasmacytic islands that would be a lupus profundus.
I mean, that's on facial skin, but do you usually see lupus profundus on like the face?
You can see it anywhere. I mean, more commonly where you have more fat, right? But you will see people who develop a Perry-Romberg-like condition, and it's not Perry-Romberg, but it's lupus paniculitis just chewing up, and when you see it on the face, it's really disfiguring, and you want to be sure you nail the right diagnosis so you get them on the right treatment.
And was that erosion because of like an interface dermatitis? I don't think, or do you think someone did something to it?
I think that was probably, like there was my guess is there was a shave that was non-diagnostic, and so they ended up doing something incisional because this person's face is caving in. And, it would get, whereas Perry-Romberg, you'd be more methotrexate. For this, you might be more Plaquenil initially.
So this looks like acral with some serum in there. I thought like LSD kind of looked but then the bending also suggests sort of wordiness, but I don't see
So
a
sort
coil
of
sites.
warty. Do warts usually have layered corneum like this?
No.
And you said there's vertical streaking and angiofibroplasia, and there's a hair follicle, but you said it looked acral site, so you're telling me this is a hairy palm
It's a
appearance.
pseudo-acral site. The original view show did not show the palm there, or the person has reduced palm-like skin by rubbing.
So you are correct. So you have a stratum lucidum and a thick corneum that looks like acral skin, but you have hair follicle, so it is clearly, as you said, pseudo-acral or hairy palm appearance. You have areas of pink corneum. You have areas of eosinophilic necrosis of the granular layer, which is always a fingernail at work. And you have angiofibroplasia with vertical streaking of the papillary dermal collagen, so that's all prurigo.
This wedge-shaped scar here.
So wedge-shaped, and you said the word scar.
Wrong word.
Well, maybe yes, maybe no. it was a word choice. Do scars usually have dendritic melanocytes in them?
No.
Like a
But I will say, Dr. Elston, I was thinking blue nevus, so I didn't really mean.
So what you meant was a wedge-shaped area
Fibers.
of unique, dense collagen that's clearly distinct from the surrounding dermis.
Yes, exactly.
And you are absolutely correct, Blue Nevus. Well
I
done.
wouldn't have picked wedge-shaped scar on the board.
Wedge-shaped scar. I hope that's in there. Those things.
Because if there were truly wedge-shaped scars that were smaller and more superficial, then you'd think of things like LPP or folliculitis decalvans. whereas this was a bigger wedge-shaped lesion. In general, benign lesions, be they lymphoid or melanocytic, the point of the triangle's at the bottom. And malignant ones, the point of the lesion is often at the top. So that's, what we say bottom heavy or top heavy. Means where is the big flat part of the triangle?
It's a lot of blood vessels and superficial dermis.
Yeah.
Like a cherry angioma or angiofibroma.
Cherry angioma, angiofibroma. How many of those have a collarette?
Maybe neither of those. Maybe
Yeah.
like a PG.
Yeah, collarette suggests it was maybe eruptive, maybe like this is an older PG. There's some suggestion of fibrosepty, like it was a lobular proliferation.
Okay.
PGs always have a feeding little arteriole, so essentially they're fancy arteriovenous malformations that are distinctly lobular, eruptive, and start as packed endothelial cells, and then with time they age and they become more ectatic. How are we doing time-wise? We got 5 minutes.
So, looks like I have a widened minus follicle with some material being extruded out.
So a big mama follicle and lots of little follicles emptying into it.
Like trichofollicular.
Like a trichofolliculoma. Very
I
good.
actually think anthoma.
Yeah, I know.
I always get those.
Yeah, they're
Looks like a superficial dermal infiltrate,
Superficial dermal infiltrate and
some pigment,
some pigment. And is it a little pigment or a fair amount of pigment?
fair amount.
And yet there's not a whole lot of infiltrate, right?
Mm-hmm.
So when you have too much pigment and too deep and too bulky to have been inflammatory in origin, that's what we call tumoral melanosis. And tumoral melanosis usually means regression of a tumor, right? So that was regressed melanoma. So the idea is you see pigment incontinence, but it's too deep, too much, too bulky to be inflammatory. So it's tumoral melanosis. I sent you a picture, Katie, this morning, an article that looks exactly like this, the image and the picture.
If only I was Katie right now.
So what you have is you have little circular vessels, and then around it, a rosette formation of these round cells around the circular vessels. So, anyone want to jump in? Myopericytoma. So myopericytoma is the article I sent you kind of puts it on the spectrum with myofibromas, but they look different. Myopericytoma, you have vessels, so it looks like a vascular tumor, but then the tumor is really all of these rosettes of round cells around those vessels. So there are the pericytes around the muscular vessel, so a myopericytoma.
Let's see. Blue tumor with little areas of red. No, I was looking for lymphocytes. I might see if you look at
So if there were lots of lymphocytes, then you would think of a spiroadenoma, and if it's more jigsaw puzzle with surrounding basal membrane zone, then you're thinking
cylindrome.
cylindroma, and it's variants of the same tumor. Spiroadenoma, cylindroma. The cylindroma is more jigsaw puzzle, less inflamed. The spiroadenoma is bigger blue balls, more inflamed and therefore tender. Remember that you can get little droplets of the basal membrane zone within the tumor as well as the thick basal membrane zone material at the periphery. Very good.
I think we're good. Can the plywood wood
Plywood
grain.
div.
Plywood, or if you were an art history major,
The question sort of implies that they are.
Van Gogh.
which
Starry
Van
Night.
Gogh painting?
Starry.
Starry Night. So that would be good for
Lowe's. Home Depot.
sclerotic.
And
So
carbon.
sclerotic fibroma, which can be a marker for Cowden syndrome, so it also gets called Cowden's fibroma. And it does. If you look at the sky in Starry Night, it's certainly a similar pattern. In fact, the rumors are that that Van Gogh wanted to be a dermatopathologist, and he was trying to recreate a sclerotic fibroma.
This is kind of like a mixed tumor.
Kind of like a mixed tumor. It has a branching alveolar pattern of ducts in some areas surrounding connective tissue, which can be fat, can be gray-blue of cartilage. So very good.
Watch your face.
We got 2 minutes. We ought to be able to do 10 slides, right?
All right, come at
Is
us,
that a
bro.
challenge?
What?
Job.
I'm just kidding. Come on. Oh my goodness, I'm trying. So it's most like breast cancer is what I would think.
Yeah, exactly. So horrible
Native American filing.
hyperchromatic cells, single filing, Native American filing, Indigenous American peoples filing, whatever you want to call it. So hyperchromatic
Oh, that's good.
cells
That's what's like at the board.
in a single file,
So it's like,
and nuclear molding, which is, horrible breast.
Okay, we're gonna continue that.
oh, good, good, good. Appropriate.
Okay, so I hear go, go, go.
Big chunk of. Okay.
Keratoacanthoma regressing.
Next one.
This is a big crater-formed thing with too much keratin to have been made by that. I'm sorry, I'm going too slow.
Big chunk would have been on your pick list.
That's what I said. Okay.
Big chunk.
Ooh, it looks like it's got a
Must be a piece of
desmoplastic trichomonas for MAC or
So very good. So you see a Paisley type pattern with horn cysts. So you said desmoplastic trichoepithelioma, microcystic adnexal carcinoma, morpheoform BCC, or syringoma, depending on history. This is sun-damaged skin. So syringoma becomes less likely. Actually, desmoplastic trichoep becomes less likely, and now you're more worried about morpheoform BCC or MAC. Okay.
Oh, big piece of tissue.
Also on your pick list.
Is it a
So what's the
proliferative
predominant color?
Purple.
So purple or blue with ducts. What's blue with ducts?
So sweaty tumors.
What's blue with ducts?
Oh, sebaceous.
Very good.
Sebaceous.
Done. Okay, well done.
Dang it, we didn't get our goal.
We got
4 out of 10. I mean,